Since pain is one of the most common symptoms which causes a patient to seek medical advice, complaints emanating from the musculoskeletal system account for a large number of visits to the doctor's office. Understanding the normal physical examination of the musculoskeletal system is therefore of paramount importance. Prior to the commencement of the physical examination of the musculoskeletal system, a thorough and accurate history must be obtained from the patient, and although not the emphasis of the present series, the importance of the history cannot be overstressed. The history pertaining to the musculoskeletal system frequently points to the correct diagnosis or a very short list of differential diagnoses, and the precise diagnosis is confirmed on physical examination. As in the examination of other systems, an orderly and systematic progression is imperative so that musculoskeletal pathologies are not missed. The exact sequence of the examination may often be dictated by the patient's symptoms or obvious findings, but the examiner must not forget to cover all aspects of the physical examination.
General guidelines. Explain. A brief explanation of what you are going to do to the patient will allay their fears and apprehensions, and also assist greatly in patient cooperation. Communicate. The patient is not an inanimate object, and maintenance of eye contact where possible, as well as verbal contact with the patient throughout the examination is important. Compare. Symmetry in the human is a consistent feature, and the examiner must always compare one side to the other. Gentleness. Gentleness towards the patient must be considered at all times during the examination, particularly during palpation. Testing passive range of motion and instability testing. Completeness. The whole of an extremity must be examined, not just the area pertaining to the symptoms. Also remember that pathology in the spine may account for symptoms in the upper or lower extremity, and therefore the spine must be examined thoroughly. Consideration. Remember that a patient with pain will not appreciate changing positions frequently during the course of the examination, and therefore it is more appropriate to cover all the necessary aspects with the patient in one position, and then move the patient to complete another phase of the examination. A general approach that allows the examiner to complete a detailed exam fulfilling the above criteria will now be presented. Equipment. Certain basic equipment is required to conduct a proper examination of the musculoskeletal system. Wooden blocks to assess leg length discrepancies, measuring tape, goniometer to accurately measure angular deformities and ranges of motion, a neurological hammer, pin, cotton wisp, tuning fork, and containers to test hot and cold sensation, and a stethoscope to auscultate arteries for bruits or to auscultate vascular lesions of bone. Musculoskeletal examination. An orderly and systematic progression includes the following aspects: inspection, palpation, bony landmarks and soft tissues, range of motion, functional, active and passive, neurological examination, vascular examination, special tests related to the area being examined, and examination of related areas of the musculoskeletal system. Inspection. Items to be considered during inspection include deformity, atrophy, discoloration, swelling, scars, cutaneous lesions, gait, posture, and movements. Inspection should commence the moment you first lay eyes on the patient. As a doctor, you are merely a detective, trying to solve the case or make a diagnosis. And the more clues you have, the easier it will be to solve the problem. The way in which the patient sits in the chair, gets out of the chair, or walks are just a few examples of where you may find very helpful clues. Remember, at all times, keep your senses, sight, hearing, touch, and smell at work. It is necessary for the patient to be properly attired for the examination. You cannot do an adequate examination of the knee with the pant legs rolled up, or of the back with the shirt pulled up. The whole of the part to be examined must be visible and accessible. Deformity. Any obvious alteration from the normal anatomy, for example, as shown in these patients with genu varum and genu valgum, should be documented in detail. Always document the number of digits on the hand and the foot, noting in this patient the absence of the second toe on his right foot. Atrophy. Significant atrophy or wasting of a muscle group or groups may be noted on inspection. Discoloration. Note any redness, bruising, or ecchymosis. Swelling. Document swelling in a numerical fashion whenever possible. For example, diameter or length and width. An orange-sized swelling may not be that meaningful to another physician or examiner, as you may be thinking of a small orange rather than a big Florida orange. Always try and describe the exact location from an anatomical point of view. Scars. These include abrasions, lacerations or wounds, as well as previous surgical scars. One should always measure the size in terms of length and width, and note the color, as these features may be important from a medical legal point of view in years to come. Cutaneous lesions. Hairy patches, hemangiomas, and other cutaneous manifestations such as cafe au lait spots may signify musculoskeletal pathology, and their presence should always be documented. Gait. Gait is an extremely important aspect of the physical examination, and it is necessary to have a good understanding of normal gait in order to detect differences and what these mean in terms of musculoskeletal pathology. As well as gait, the posture that the patient adopts when standing, sitting, or lying is also important. The way the patient moves, either as a whole or movements of the arms, legs, or back, should also be noted, as these can be important features of an overall examination. Palpation. Important features to detect while palpating the bony and soft tissues include anatomical landmarks, tenderness, deformity, temperature, swelling, and crepitus. It is essential that the examiner fully understands the surface anatomy and identifies the bony and soft tissue landmarks in order to carry out palpation properly, and localize findings in terms of the appropriate anatomy. When a patient complains of pain or tenderness during the examination, it is necessary to have the patient identify the exact source. For example, when testing abduction of the hip, the patient may complain of pain or discomfort. If the examiner does not question the patient as to the source of pain, it might be assumed that hip pain was produced, when in fact it is just the examiner squeezing excessively about the ankle. When tenderness is elicited during the course of palpation, It is essential to determine precisely the exact location, even with the fingertip. For example, tenderness elicited over the joint line of the knee may have a completely different connotation than tenderness elicited over the femoral condyle only 1 centimeter away. Deformity. Not all deformities may be apparent on inspection, and a description of a deformity on palpation, such as a mass or lump, is of paramount importance. Temperature. Temperature variation, either an increase or decrease, is important to document, and note its exact location, and always compare to the opposite side. Swelling. As well as the size and exact location of swelling, characteristics such as fluctuation or induration must be described, and palpation will add refinement to the visual inspection. Crepitus. Crepitus, or a grating sensation or noise, may be palpable or even audible during the examination. Crepitus may arise from joints in patients with arthritis or in inflammatory conditions of the tendon sheaths known as tenosynovitis. More serious conditions include fractures or air in the soft tissues, such as in subcutaneous emphysema or gas gangrene. When examining joints, it is essential to document the range of motion. Most textbooks on the physical examination of the musculoskeletal system give a range of joint motion for each joint. For a particular patient, however, often the expected normal range can be determined by examining the normal, uninvolved side. It is often said that the only reason we have 2 arms and 2 legs is for the orthopedic surgeon to be able to compare one to the other. Thus, always compare with the opposite extremity. When examining joint motion, it is important to know what motions the particular joint being examined is capable of. Obviously, the hip joint has more ranges of motion than does the ankle joint. Functional range of motion and both active and passive motion must also be tested during the course of the examination. Active motion is performed by the patient alone, whereas passive motion is that range that the examiner can obtain and therefore does not depend on muscle strength. Passive motion, if performed gently, is less likely to elicit pain than active motion. Therefore, differences between active and passive motion can yield significant clues as to the diagnosis of the problem. Always document ranges in degrees using a goniometer for accuracy. Neurological examination. The complete examination of the musculoskeletal system requires a detailed and thorough neurological examination, and is especially important in multiple trauma, spinal disorders, and primary neurological diseases with musculoskeletal manifestations. It is essential to examine the sensory dermatomes and to know the root and peripheral nerve innervation of the various muscles and reflexes that can be tested throughout the body. Sensory examination. All of the dermatomes related to a specific area must be examined. It is necessary to examine responses to various sensory modalities, such as pinprick,
Sharp.
dull touch,
Dull.
light touch,
Yes.
temperature, both hot
Hot.
and cold,
Cold.
2-point discrimination,
2. 2.
vibration,
Yes.
proprioception,
Up. Down.
and deep pain in order to accurately localize a deficit in the sensory system. Motor examination. In order to adequately assess the motor system, the examiner must know the muscles that act about the joint being examined and test each muscle or group of muscles in terms of strength. Also assess muscle tone, differentiating states of hypertonicity or hypotonicity from the normal. When possible, always palpate the muscle belly and or the tendon of the individual muscle being tested. Numerical documentation of the grade using the International Muscle Grading Chart is essential. Grades range from 5 or normal, complete range of motion against gravity plus full resistance, to 0, where there is no evidence of contractility. The numerical grade is more specific to follow changes, and a description such as slight weakness of the tibialis anterior has very little meaning to another examiner or even for the original examiner several weeks or months later. Always document the measured circumference of the limb and compare to the opposite limb. For the measurement to be compared, it is essential that both limbs be measured at an identical level, and this needs to be ascertained by marking the level on each extremity in relation to a fixed landmark. For example, in the examination of the knee, the fixed landmark would be the medial joint line of the knee. Reflexes. Deep tendon reflexes, superficial reflexes, and pathological reflexes must be tested and recorded in terms of their presence and grade or absence, and reinforcement may be necessary. Always compare to reflexes on the opposite side. Often, a body diagram is useful to document the sensory abnormalities and the reflex grade. Vascular examination. Since limb viability is dependent upon its blood supply, the vascular examination, including the palpation of pulses, is absolutely essential, whether conducting the orthopedic examination for an acute injury or a chronic condition. A detailed vascular examination should assess the skin, hair distribution, capillary return, arterial status, venous status, and exercise effect. The vascular exam should be done on the same basis as any other system, that is, inspection, palpation, and auscultation. Skin. The examiner should note texture, color, and temperature of the anatomical site being examined. Hair distribution is often a good indication of adequacy of perfusion, especially in the lower extremities. Capillary return. Digital pressure is applied to the area being tested, for example the nail bed, and the time for return to normal color following the release of pressure is recorded. Arterial status. Palpation. All the palpable pulses which can be identified must be sought, and their presence and volume or absence must be recorded. Obviously, performing surgery on a vascular compromised extremity may lead to disastrous results. Auscultation. Auscultation is used to detect bruits in the vascular tree. Aneurysms are a common cause of bruits, and auscultation of the popliteal artery is important in differentiating a popliteal aneurysm from a Baker's cyst. Vascular lesions of bone, for example metastatic renal cell carcinoma, may give rise to bruits which can be auscultated over the lesion. Venous status. The status of the venous system must be ascertained. Recognition and documentation of varicosities and stasis dermatitis or stasis ulcers is of extreme importance to the orthopedic surgeon. Exercise effect. The response of the vascular tree to exercise is important, especially when previous portions of the vascular examination have indicated the possibility of vascular insufficiency. Not every pain in the calf region is due to a ruptured intervertebral disc pressing on the L5 or S1 nerve root, and treatment addressed to that area would not solve the problem of vascular claudication. Special tests. In various areas of the musculoskeletal system, there are specific tests designed to test a function that would not be applicable to another area of the body. For example, a test designed to examine the integrity of the anterior cruciate ligament of the knee is not applicable to the hip or elbow, where there is not an anterior cruciate ligament. Thus, during the examination of a particular joint or area of the body, specific tests will be discussed which are applicable only to that area. Examination of related areas.
The examiner should not limit the examination only to the area of chief complaint, as this may merely represent a manifestation of a systemic disorder, or conversely, it may represent referred pain from another area of pathology, which would be missed if the appropriate exam of the related areas were not performed. One of the most classical examples of referred pain is in the limping child complaining of knee pain, where the pathology, in fact, resides in the hip joint. Other examples would include back pain from abdominal aneurysm, duodenal ulcer, or pyelonephritis, and hip or groin pain arising from lower abdominal or retroperitoneal pathology. In summary, the physical examination of the musculoskeletal system must be performed in a systematic way so that no pathological condition is overlooked.